One, we are live to the attendees platform. We can start this meeting. Over to you, sir.
Thank you. Thank you. So good morning all. Welcome in the module 5 of our Basics of Allergen Immunotherapy course. We are really delighted to have with us Professor Shoibal Moitro, who is currently the professor at the Department of Respiratory Medicine and Division of Allergy and Immunology in Apollo Hospital, Kolkata. He is also the medical director of Allergy Asthma Treatment Center in Maulali, in Purnodash Road, Kolkata. So, welcome, sir. And at present, also we have with us one of our panelists, Dr. Vijay Warad, who is a very well-known figure in the field of allergy medicine in India. Sir is from Pune. Sir is pulmonologist and allergist there at Pune. So welcome, sir. We are really delighted to have you with us. Also, we'll get the important message from Professor Raj Kumar, Dr. Soumya Nagarajan. They will join at around 11 for the panel discussion. So on behalf of Indian College of Physicians, we are really happy to conduct this course on basics of allergen immunotherapy. And under the guidance of Professor Jyotirmoy Pal, who is currently the Dean of Indian College of Physicians, we are conducting this course. So already we had some view over allergen immunotherapy, the basics, but today we'll learn a little bit in details about the prescription writing on allergen immunotherapy. So now I am requesting Professor Shoibal Moitro sir to start the class.
Thank you, Dr. Shamra Shamasta. I'm really delighted to be a part of this, a very successful program. And I'm honored that I have been invited by the Indian College of Physicians to be one of the faculty in this webinar series. Today, my talk is on allergen immunotherapy prescription writing. When I was assigned this topic, I was wondering that how can I make a justice to a topic which I usually teach as a chalk and talk in a classroom teaching. So taking it up on an online course was a big task for me, because as I do understand that giving a prescription for the immunotherapy, it requires as much of training, knowledge, and practice as we give a prescription for or any other medicines and in pharmacotherapy. So I decided that as we have our usually regular prescription teaching classes, so this talk would be somewhat of and just as a primer to what we usually do, so that we understand that what are the basic tenets which has to be kept in mind while we are giving a prescription of the allergen immunotherapy. And so that when we actually take up a like day-long teaching practical classes of the immunotherapy, we would be more or like attuned to the entire topic. So I thought that I'll reframe my topic as the nuts and bolts of the prescription writing, because if you have the nuts and bolts right, then only the wheel will start moving properly. Okay, so my majority of the slides have been adapted from the Quad AI teaching slide set. So I am really indebted to Quad AI for allowing me to use the teaching slide set for this purpose today. Just a brief. So before we give a prescription for the allergen immunotherapy, we should have a stoic confidence on the immunotherapy. We know that immunotherapy works. We have multitude of the evidences, and the mechanisms of it are multifarious. which affects all the parts of the immune system, whether it's the innate immune system or the adaptive immune system. So by and large, the majority of its mechanism which has been elucidated so far, I'll just touch upon few, not all. One is the regulatory T cells. We talk about the immune tolerance, and to bring about the peripheral immune tolerance, one of the major key players are the T regulatory cells. The increase in the T regulatory cells, namely which are CD4 positive and CD25 positive or FOXP3 positive T cells, production of the increased levels of the interleukin 10, and which is a suppressor cytokine, suppresses Th2 immune responses, and another suppressive cytokine, that is the TGF beta, which also reduces the Th2 responses. On the other hand, and it is also involved in the immune deviation. We say that it is the Th2 to Th1 deviation to the increased production of the Th1 cytokines, the signature cytokine being the interferon gamma. We have the immunoglobulin class switch deviation, which is a part of the immune deviation story. So there's increased production of the allergen-specific IgG, namely IgG4, and to a lesser extent IgA. There's initially an early rise in the specific IgE, which is followed by a decline in the levels of the specific IgE levels. So this was a very interesting study which was done on the grass pollen immunotherapy, seasonal polycystic allergic rhinitis, and published by Francis in the JASI in 2008, quite long back. So they saw that what is the time span of the antibodies and the skin test changes, which happens in cases of the seasonal allergic rhinitis due to the grass pollen, which is a very good model to study the effect of the immunotherapy. So initially they found that the IgE level, there was an increase in the IgE levels initially in the first year of immunotherapy, which then slowly declines and to the lesser than the pre-immunotherapy levels. So that is for the IgE. Then the blocking antibodies, that is what we call the IgG4 and IgA, which slowly and steadily rises throughout the first year of immunotherapy and then goes on rising, and that is a steady state after the second or the third year. So that is for the IgG4 or the IgA responses. And the increase in the IgG4 or the IgA increased levels, it actually translates into the reduction of the immediate skin responses. It is what we call is the early phase responses are blocked by this blocking antibodies. Then we have this inhibitory cytokine interleukin 10, which rises pretty early in the immunotherapy. Let's say that is within the three months, maybe the first month, and then maintains a steady state throughout the immunotherapy. And this increase in the IL-10 and production is responsible for the reduction of the late skin response, or what we call the late phase cellular response, or the late phase response, the LPR. So this is what the mechanism by and large we know. Now next, to which patient will you give? Definitely a patient who is having an IgE-mediated disorders, namely allergic rhinoconjunctivitis, allergen-induced asthma, atopic dermatitis, the Hymenoptera and fire ant hypersensitivity may be considered in the atopic dermatitis because it is coming up. So, but by and large, for the allergic rhinitis or rhinoconjunctivitis or rhinosinusitis, and allergic asthma and the stinging insect allergies, these are the main indications in which we give the immunotherapy. Because until unless you know the conditions for which you are prescribing this, definitely it's not going to be a right treatment. So, and how safe it is? It's a very safe mode of modality of treatment. Can be given in children, it is safe in children, it is effective and well tolerated. And usually they are given in conjunction with the pharmacotherapy and allergen avoidance. We know because there are 4 pillars of the allergy treatment. Namely, one is the pharmacotherapy, another is the allergen avoidance, and third is definitely the immunotherapy, and fourth is the education. Pregnant woman, allergen immunotherapy can be continued in the pregnant woman, but the doses are not increased. and sometimes they may be reduced. But it is not initiated in the pregnant woman because of the fear of having an anaphylactic reactions. So this has been well documented in the practice parameters of the published in the JASI. But when we do not give the immunotherapy, namely if the asthma is uncontrolled, we do not give the immunotherapy. If the compromised lung function, that is the FEV1, is less than 70% of predicted, patient has a recent unstable angina or a cardiac event or MI, significant arrhythmias, uncontrolled hypertension, a major organ failure, we do not give the allergen immunotherapy. And obviously, if the concomitant medications are there, we need to judiciously balance between the risk and the benefits. As a beta blocker is a relative contraindication for the allergen immunotherapy. And for the venom immunotherapy, it's not a contraindication. We have to give possibly on the AC inhibitor, patient on AC inhibitors, but definitely the individual risk benefit analysis has to be done for each patient. Very, very important is that we should have an informed consent before the patient is started the immunotherapy. As we do it for any other treatment modalities, for any other interventions we do, we need to have an informed consent. So patients should be informed of the nature of the subcutaneous immunotherapy, if we're giving the subcutaneous immunotherapy and any other alternative treatments that is sublingual and all. Potential benefits and risks has to be explained. The costs needs to be detailed. The anticipated duration of treatment, very, very important. It is 3 to 5 years. Patients should know at the outset the treatment is going to last for 3 to 5 years. And there's any specific policies that is you need to come to the clinic once a week or things like that. And they should be known that they may not have any clinically discernible improvement in the 6 months. So they have to continue with their usual medications, and the dose changes of medications will be done by the physician itself after assessing the patients in the subsequent and follow-up visits. So that needs to be said beforehand. It's very important because unless we have informed consent, we are not making sure that the patient will comply with such a long treatment. Okay, so that's going to be a failure of the entire exercise and will defeat the purpose. So obviously, definitely we should have informed consent for each patient. Now comes this very important concept of the allergen dose. As we know about in writing in medicines about the medication dose, so here we should know about what is the allergen dose. It is that dose which is given of each allergen in each injection and which is needed to have an optimal therapeutic effect, the optimal therapeutic dose. And efficacy depends on this optimal therapeutic dose. It's very, very important. The content of the allergen extracts, it should be based on the clinical history, the allergy test results, and the possible specific ID test results, which have been correlated well with the patient's history. Then only we have to decide that what are the allergens we need to choose. So that is beyond the scope of the today's talk. This individual mixture of the projected effective doses referred to as a maintenance concentrate. So if we are giving like 2 or 3 allergen mixes together, that means you have to calculate that is the allergen dose for each of the allergen which is there in the mixture, and then the mixture which is produced is known as the maintenance concentrate. Like the maintenance dose for each allergen in a particular mixture. So, and the total concentrate is called the maintenance concentrate. I'll talk about it in somewhat more detail when we just go into the subsequent slides. Now, this is important to know that there's a probable effective if those ranges are there. Okay, so this is like we have the standardized allergens with non-standardized allergens in the US, and India we have non-standardized allergens. But that does not make a very much difference as far as the effectivity of the immunotherapy is concerned in our population that we have seen, because we have been working with the non-standardized allergens for all these years, and people are getting benefited with that. For the DF and DP, the labeled potency or concentration is 3,000, 5,000, 10,000, or 30,000 allergen units per ml. But probable effective dose range is 500 to 2,000 allergy units. That is the effective dose. Similarly, for the cat here, we have the 1,000 to 4,000 biological allergy units for cat pelt, similar like that. But if we go to the non-standardized allergens, like in India, we have all the non-standardized allergens. And so like if we take that for the dog dander, and see that it is 1:10 to 1:20 weight by volume is the concentrate, which contains about 15 micrograms of CanF1. Now for the pollens, it is the 1:10 to 1:40 weight by volume, and which is the effective dosage is 0.5 ml of 1:100 or 1:200 weight by volume. This is what we commonly use in our allergen extracts that we give to our patients. The subcutaneous, this is all is I'm talking about the subcutaneous immunotherapy. Like for the imported fire ant, it's the whole body extracts so that we use. The 1:10 to 1:20 weight by volume is the level potency, and the dose range is 0.5 ml of a 1:100 weight by volume to 0.5 ml of a 1:10 weight by volume extract. That is the available dose range. Why this dose range? Because it's a tolerability. Okay, so somebody can tolerate a higher dose, someone may not tolerate that higher dose. So it depends upon, but we know what is the lowest effective tolerable dose, what is the highest effective tolerable dose. So that's why this dose range are there. Now this is a very important calculations, and which we need to do for while we are calculating the dose and giving a prescription. Now, this is the formula which we have to keep in mind and use it again and again and again for each prescription immunotherapy. That is V1 into C1 is equal to V2 into C2. What is V1? V1 is the final volume of the allergen extract in a bottle which we want to have. Okay. C1 is the concentration. Here we give by weight by volume. So I'll be talking about the weight by volume only of the extract that we want to prepare. V2 is the volume of extract you will need for dilution. Okay, and C2 is the concentration of the extract that you will use. For the majority of the allergens, like if you take say the pollens or maybe the dust mites or whatever it is, the manufacturer usually have a stock solution. The stock solution concentration is mostly 1:20 weight by volume. Okay, so that means, and you have to order the prescription keeping in mind that the stock solution that they will be using is 1:20 weight by volume. We need to have a prior information from the manufacturer in which we are giving the prescription about what is their stock solution concentrate. Some concentration may be differing, some may say it is 1:10, then we have to calculate it by this formula. Now, see, we know the final volume that we want to prepare because it is usually 5 ml. You may want to prepare 5.5 ml in one bottle, some may be 6 ml, but usually the 5 ml is the most commonly prepared, or maybe the 5.5 ml if you want to factor in the wastage volume. Now the concentration that of the extract that you want to prepare. Usually what we say is that the maintenance vial concentrate may be 1:100 or maybe 1:200. So mostly for the pollens, it may be 1:200 or maybe 1:100. For dust mite, it is 1:100 weight by volume. So that means the V1 is 5 ml. C1 is the 1:100 or 1:200, whatever it is you want to prepare. Now C2 is the extra level we use, that is stock solution of the manufacturer that you know is 1:20. Now, so what you need to find out is a V2, is how much of that extract you will write in the prescription that the manufacturer will put in while they were making it allergen immunotherapy extract vial. So then that is solving for the V2 is V1 into C1 divided by C2 is the V2. Okay. So say in this example, This is from the Allergen Compendium for the Greer Labs. So that is US based. That is a V1 is 5 ml. C1 they want to have a 1 is to 200 concentrate, that is for the 1 is to 200. V2 we need to calculate, and the C2 is 1 is to 10. So if you calculate this and put it all over here, always remember that there is the 1 is to 10 of this fraction has to be changed into a decimal while we are doing the calculations. So it is 5 into 0.005 is equal to V2 into 0.1. This V2 is equal to 0.025 divided by 0.1. That means 0.25. That means if you're using only one of the allergen, say allergen A, and which you need to have in a concentration of 1 is to 200, then the amount of that extract that we'll use in the stock solution has 1 is to 10 that concentration, then you will need 0.25 ml of that extract. It has to be written. Now, if it is a monocomponent allergen immunotherapy, like only you're giving, say, dexamethasone DP, then this is 0.25, but your entire solution is 5 ml. So that means the diluent that we need to use, the amount of diluent is 5 ml minus 0.25 is 4.75 ml. The 4.75 ml of diluent plus 0.25 ml of the allergen extract A, maybe DP. Now see, if there are three actually the allergens, allergen A, allergen B, allergen C, which you need to put into it. So maybe dermatophagoides teronicinus, dermatophagoides perini, or maybe some pollens like say Cocos nucifera. So that means for each of this allergen, you need to know what will be the C1. As I've said, C1 is mostly 1 is to 200 or 1 is to 100. Okay, that's the concentration it is to use. But for the stock solution C2, you need to ask manufacturer what is the stock solution concentration for each of these that they have. Only when they have provided you with that information, you'll be able to compute what is the V2. So you find out V2 of A, V2 of B, V2 of C. You add all these V2A plus V2B plus V2C, and then you say you find a amount, say X. So that has to be subtracted from the total volume is 5 ml, so that you will understand how much volume of diluent you will use. So you have to write in the prescription the diluent and this much ml. Say if it is a 3-component allergen therapy you're giving, so you have to write that the V2, one component A, say the DP is say this much ml, then the DF is this much ml, and pulmonary Cocos nucifera is this much ml. And this is the prescription which you have to give to the manufacturer. So that is that the highest the maintenance vial concentration that the manufacturer will produce. We do not end over here. Now there's another task. This is the concentration that you have calculated for the maintenance vial. But you do not start with the maintenance vial. You have a builder phase before. You start with a very dilute solution and then move up. Now this dilution, and also you can order it to the manufacturer, or you can dilute it in your own setup or clinic if you have an allergen extract compounding area. So there's special training they give, that is a USP, that is a training that they give for the how to do an allergen extract compounding. And they have some practice parameters also, the quad AI, that you have to know. But by and large, the main thing is that you need to have a clean area where you can do the compounding. Compounding is only doing the mixture. For that, you need to pass several tests like the finger glove test, gloved finger tests. Then you have the tests. Okay. Anyway, so that means what you do in the allergen extract compounding in your setup is that you do the dilutions for the buildup of vials. Okay. Now, how do we do the dilutions? That I'm coming. The first understand that we have calculated the maintenance vial, okay, concentration. The immunotherapy treatment has two phases. One is a build-up phase, another is a maintenance phase. This I'm talking about the subcutaneous immunotherapy. And the maintenance phase injections are remains those of the injections and of the allergen per injection remains the same. Okay, and which is given either once a month or twice a month, depending upon what you choose. But the build-up phase, actually it differs. And depending upon that how quickly you build it up, you can have a uh, conventional schedule. That is, you give a once or twice injections in a week, or you can give a daily, or you can have a cluster schedule where we actually club 2 or 3 injections each visits, or we can have a rush, modified rush and ultra rush schedules where you build up maybe within 7 days, within 3 days, within a 1 day, things like that. That is definitely has a little bit increased risk of side effects. Anyway, depending upon what happens is that how quickly you build up the build-up phase, you have these various schedules. It could be conventional, it could be daily, it could be cluster, it could be rush, it could be ultra rush. But the maintenance phase injection remains same. Whatever schedule you, this is how fast you build it up to maintenance phase. Now, so this is you start with this is injections, very dilute in injections, then you just move up, move up, move up, you reach the maintenance valve. Then you reach the maintenance dose. That's the highest dose. That is the dose that you've calculated. That is the effective therapeutic dose. And then you have to give it either once a month or twice a month. And this is how you continue. Initially, may give it twice a month. Then you make it once a month. So this is the schedule of the subcutaneous immunotherapy that we usually follow. Now we come to the allergen extract compounding. So what this is a color code. This is a universal color code. That is the maintenance vial will have is a red cap. Then, as with the decreasing concentration, red, yellow, blue, green, silver is the most dilute solution. Mostly we do not use silver. We start with green and go up. So that means it's a red, then yellow, then blue, then green. Start with green, then go to blue, then go to yellow, then go to red. Now, initially the formula which I have just narrated, and you have prepared the allergen extract, that is actually the maintenance valve or the red valve. So if we take the volume by volume, that means it is 1:1. Now, if you make it a 10-fold dilution, that is, you make it 1:10, you come to the yellow valve. You make it 100-fold dilution, that is 1:100, it becomes a blue valve. You make it 1,000-fold dilution, becomes 1:1,000, and becomes the green valve. And some instances you may want to make it 10,000-fold dilution, becomes a silver valve. So you see that as we go down, the number that is 1, 2, 3, 4, your dilution increases. So with the increased dilution, patients are able to tolerate that more, but always understand as the dilution increases, the potency or the shelf life of that concentrate decreases. Okay. Usually in the maintenance valve, which is if you're prepared at 1:100, usually it stays for, that is the expiry date, or what we call the BUD or the beyond use date. It is around 6 to 8 months, 6 months. But if we have come to very dilute solutions like the green, usually the BUD should not be more than 1 or 2 months, maximum 3 months, usually 1 or 2 months. So that means when you are actually compounding it in your setup, then you have to use from the date of the compounding, you have to calculate a 3 months or maybe 2 months, depending upon what is the concentrate that we're using. And you have to write that date also, which will be a BUD, and which will direct that the patient should not be using that vial beyond that date, since the allergen has lost its potency beyond that. But it has to be maintained properly in 48 degrees Celsius. That's another thing. So this is important to understand. This can be prepared by you in allergen extract compounding area, or you can ask the manufacturer also to prepare it and send it to you. But then you have to be very clear about the date on which they have done this compounding, because then you have to understand what is a BUD. So usually they give the BUD accordingly, and you have to use it in that way. So this is how the dilutions of the maintenance concentrate is done. We usually start with the green vial, then we go up. This is how we do. So after we have achieved the maintenance dose, then it has to be continued at 2 to 4 weeks of interval. And it's recommended provided clinical improvement is maintained. It's definitely there. And optimal maintenance dosing correlates with the clinical efficacy. The duration is 3 to 5 years. There can be some local reactions which can occur, like the redness, swelling, and heat at the injection site. They are not uncommon, but they usually appear, and you need to tell the patient before that. And after taking each injection, patient have to wait in the clinic for around half an hour before they leave. The large local reactions are not necessarily predictive of future systemic reactions. It is very, very important. And this does not warrant the stoppage of the immunotherapy. And these large local reactions are also, they do not actually foretell the the future systemic reactions, as we know in case of the venom immunotherapy even. The large local reaction is treated symptomatically by giving a cool compress, then pre-medicate with a H1 blocker, or if we temporarily adjust the dose, or do not give too much of the injections at one side, distribute it into 2 or 3 sites. That's all can be done. So where you will give the allergen immunotherapy? Give the allergen immunotherapy in your clinic, in your OPD. The preferred location is the clinic of the physician who has prepared the extract immunotherapy. Extract, who has done the compounding is preferred, but nowadays mostly what we do, order it from the manufacturer, but it has to be stored in your place properly. And it has to be administered under supervision of appropriately trained physicians and other healthcare professionals who are involved in it, whether it's paramedics and all. The trained nursing staff, they must be familiar with the following. First, adhering to prescribed schedule adjustments, that is the which vial, what, when to give injection schedules, that will be prepared by you. It should be able to recognize and treat adverse reactions like the large local reactions and all. They should be trained to give the epinephrine stat in case they suspect impending anaphylaxis before ringing you up, or maybe before you arrive. They should be trained to give the epinephrine, basic CPR, obviously, and patient education fostering allergic recognition reactions needs to be, they needs to understand that. But many times the patient may say that it's not feasible for them to come to your office, say every week or twice a week. So they may want to take it somewhere near their home. So this is also possible, so given the guidelines. But obviously the injection should not be taken at home. It is not at home therapy. A prescribing allergist, like who is prescribing, need to properly prepare, label the extract with the BUD. Schedule and administration instructions should be written very clearly. The administration schedules, that the vial one is green, blue, yellow, all these vials, red vial, all the schedules should be written properly. When to postpone injections, reduce dose, and call the allergist has to be written. Risk factors has to be stated properly. An annual follow-up with the allergist is recommended, maybe biannually or maybe annually. And they should ensure that whosoever in whatever setup the patient is taking the injections, it has to be a qualified physician and staff. They should understand the right patient, right vial, right dose, right schedule. pre-shot screening and document and observe for more than at least 30 minutes should be there. And obviously in that setup, they should have a 1:100 weight by volume of epinephrine to be given IM. There should be stethoscopes. Doctor should be there with all the equipments, little syringes, IV setup, oxygen, and airways, and medicines like antihistamines, corticosteroids, preferably glucagon if somebody is not responding to epinephrine anaphylaxis. So that means it has to be in a medical setup. So, but near the patient's home, maybe not in the allergist office. That is responsibility of the allergist who is actually prescribing the immunotherapy to be taken outside his clinic or office. This is very, very important. This is also there documented the third practice parameter of the allergen immunotherapy published in JASI in 2011. So what we understand from all this is that allergen immunotherapy is safe, it is very effective in a variety of allergic disorders. We need to understand and select the right patient, then the right allergen, and obviously the dose, what should be there that we calculated right from the chart that I've shown. The clinic administering immunotherapy should require the person should be trained, proper equipment should be there. There should be standardized practices to minimize the risk. New methods and patient options available, but they're coming in the pipeline. Refer the patient with allergic conditions early. We should urge that all other physicians who are seeing this patient, and if they are allergic conditions, they should refer them for early for consultation immunotherapy, especially in case of the allergic rhinitis. Thank you.
Thank you, sir. Thank you very much for this lucid presentation. And I think one of the most important part, what you had taught all of us that about how to calculate the dose. So that is, I think, very important when how much we should order to specify the allergen immunotherapy need. So, sir, there are a few questions that had been raised by our students because I will leave you by another maybe 5 minutes like that, sir. But this is one important questions. I think many of them had asked that how do patient-specific factors like age, allergy type, and severity influence the prescribing of allergen immunotherapy? Would you see, sir, please?
See, the thing is that patient-specific factors are most important is their sensitization and allergy status. Okay. So maybe we need to understand that's why it is important that after we have done a properly selected allergy skin prick test or maybe specific IgE, we need to go back in the history and correlate it with the history that whether the allergen which is showing positive at sensitization or skin prick test specific IgE which is there in the patient's environment, it is responsible for the patient's symptoms. Okay. Which we usually do when we come up with for the pollens, the seasonal pollens. Maybe it is showing positive, but the patient is showing symptoms out of that pollen season. This is one of the important factors. So that's how we actually precisely select the allergen. This is one of the most important patient factor. Another thing is that age. As I have said that, see, in the young adults, in children, allergen immunotherapy works best. Okay. For the older adults, the efficacy of the allergen immunotherapy somewhat decreases. So that means if the patient is young and the children, then definitely the allergen immunotherapy has a big place. For the older the patients, like the patient, if is showing that allergy to a particular allergen, then there is not much changes in the dose that we calculate. Another thing is that how to calculate the optimal dose. Okay, so optimal dose you reach only in the maintenance phase. Optimal therapeutic dose you reach in the maintenance phase. So before that, you start with the diluted dose. So what happens is that when you are scheduling and the immunotherapy, building it up, then we understand that in some patients we can build it up quickly And some patients, we are not able to build it up quickly because the patient might be having a large local reactions, or patient might be not be having some local reactions. So we need to reduce the dose and build it up slowly. So the dose calculation is not dependent very much upon the patient's other demographic factors, but the dose titration, the building up of the dose, is very much patient specific. It is not that one size fits all. It's not like that. So you have to individualize the up titration of the immunotherapy vaccines according to the patient's tolerability. So gender, there is no difference. Usually we do not have. But as I've said, that is in the pregnant woman, you do not build up the dose. You continue on the same dose, or maybe needed to reduce the dose till the child's delivery. So these are the factors which needs to be considered while we are actually administering immunotherapy. For the calculation of the dose for the allergen, it remains more or less the same, depending upon which allergen the patient is exposed to and causing the symptoms, and which is a major allergen in the patient's community. And you calculate that whatever means concentrate you have, accordingly you calculate it.
Thank you, sir. Thank you very much. And again, I want to thank on behalf of Indian College of Physicians. So thanks a lot, sir. So we get grateful to you for your presence, valuable lecture. So now we will have to move towards the panel discussion. And I think for that, we are really fortunate to have with us Dr. Varad. So welcome, Dr. Varad. And so we'll also have Dr. Soumya Nagarajan. Actually, madam is currently in one conference at food allergy conference that has been organized in, I think, in Indonesia, like that. So madam will join very soon. But before that, I want to ask Dr. Varad, because you have a huge experience on allergen immunotherapy in India. So can you please share your practical experience with allergen immunotherapy with all of us?
Yeah, first of all, I'd like to thank you for giving me the opportunity. And Saibal sir, always like opening batsman, he has already covered most of the thing. I mean, even with the question answers, also now somebody asked about the things. So in allergen immunotherapy, still we are also learning actually. It does not fit like for all everything. And even like antibiotics we give milligram per kg, the same way the allergen immunotherapy is not demographically like weight or how much is the sensitivity for the comparing to the histamine and all. So, but the basic, like whatever sir has said, that concentration we can make it, and accordingly, like 0.1, 0.2 ml, depending on the twice a week or once a week, we have to start with that. And combination of the allergen extracts also is very important. That also we learn always through our own experiences, and depending on which area we are practicing, which type of pollens are very common in the vicinity. Because sensitization can happen if the patient travels different places, but the clinical correlation we have to determine according to the exposure in that area where the patient is getting exposed to those pollens specifically. So accordingly, we have to build up the phase, and in the build up phase, most important is that specifically in Pune city, because very few, whatever like before me, who were used to practice about the allergen immunotherapy, most of the time the oral form was practiced. So subcutaneous immunotherapy in Pune or Maharashtra is very less used before me. So we have to always guide the patients, like if any small reactions also inform us immediately. So what we do practically is that always initially I do a video consultation after 10 days, then after 20 days, and then monthly always we keep in contact with the patients so that what is happening, how he is taking the immunotherapy, and even we are in contact with the physicians if they are giving the immunotherapy or pediatricians anywhere. So that way it helps. Otherwise, what happens is suppose there is some reaction, even the localized or any systemic or any viral infections also, they are very common in India, the pollution factors. Like Pune's pollution this year, 12 times increase. So we are seeing a lot of viral infections. The people get scared because of the immunotherapy, they are having the repeated attacks or something. So we have to guide that way. Even we have to talk to the pediatricians, physicians also, which are giving the subcutaneous shots. So that way we have to go so that the patient's confidence increases. Otherwise, the most important part in India is the dropout in immunotherapy. At least my setup I have seen a lot of dropouts are there because of these all misconceptions. And again, people think immunotherapy means like a cancer immunotherapy. So they don't know it is a vaccine shots. It's not immunotherapy. It's not a immunosuppressants or something. So that way we have to be, and our colleagues only we have to educate about more so that uh, if anything, they should contact with us and then we can have a build-up phase properly. And then once the build-up phase is reached, then the maintenance phase don't have much problems generally. So that is the most important thing. And the coordination between the patient and the allergy center as well as the physicians or pediatricians which are giving the subcutaneous shots, that coordination also. So generally monthly, even during the maintenance phase also, we always ask the patient to have a video consultation with us, online consultation, so that that continuation is there. Otherwise, many times it happens as it's either subcutaneous and the injections are there, some local reactions are going to be there. So suppose the patient symptomatically is better, they drop out again. So we always say to continue the therapy, you keep in contact with us. That's very important. Like even routinely, the vaccines also we see up to 1.5 years, most of the people take a DPT, polio and all, and after that they forget it. Many times, whenever some epidemic happens, then only take it. The same way, the allergy vaccines and all the awareness is lacking. So the continuation and the online consultation is also very good now. At least post-COVID, the people have learned about the online consultation. That is a benefit for us also. So that's the thing.
Yeah, thank you, sir. Thank you very much. I think one question also had been raised. Can you take that, sir, Moitro, sir? Is there any a little time for you, sir?
Yes, I can take.
So the question is like that, yes, we need to be very much dependent on the history taking while guiding the immunotherapy decision, especially during the time of monitoring. So he's asking, as you had also beautifully shown one slide on the changes in the IG and how the IgG4, IgA is raising. So can you discuss the role of biomarkers, maybe in future also, in guiding immunotherapy decision, especially during the monitoring of the treatment response, sir?
See, let's go by the evidence. As of now, and in the evidence, there has been very recently an evidence for the practice of the allergen immunotherapy, which was published in this, which is taken up, brought out by the IACI. We can see that for the monitoring of the immunotherapy during the clinical practice, the only thing that has to be used is the symptom medication score. Composite symptom medication score is the only way of well validated and evidenced way of monitoring the efficacy of allergen immunotherapy. The other biomarkers, so whether it is the rise in the specific IgG4 or so the interleukin 10, or maybe the wheel diameter in the skin prick test, they are not well validated and they have not come into the clinical practice. Okay, so always remember that the composite symptom medication score is the only way of monitoring the efficacy of the immunotherapy. The biomarkers for the immunotherapy which is there, it is still a research tool. It has not come directly into the clinical practice. So gives a very clear indication that document gives it very clearly that it is basically no biomarker should be used in the clinical practice as for the routine monitoring of the efficacy of immunotherapy as of now. But maybe since there's a lot of work is going on, because we need to have some very objective way of a test doing and saying to the patient, see, your immunotherapy is working. Okay, so both the physician and the patient gains the confidence. But we haven't reached that stage yet as standing today. It's still the composite symptom medication score. Shambho, you are muted.
Oh, sorry, sir. So, Dr. Bhaskar Krishnamurthy from Mumbai KEM, he is asking that is there any guideline on how much to maximally increase the dose at each time during the build-up phase, as in not to be go beyond so many ml, like that he is asking.
See, actually means it is you rise up to the maximal dose. That is usually see at one point you do not give beyond 0.5 ml injections at each shot. So that is the maximal volume of the injection which is given, the 0.5 ml. You do not go beyond 0.5 ml because that's going to cause a lot of pain and discomfort to the patient. That's not needed also. Okay. So for each vial, you raise up to 0.5 ml, then you go to the next vial, and then again you build up and reach to 0.5 ml, and likewise you go till you reach the 0.5 ml in the maintenance vial, that is the red vial, which you have to continue once or twice a month.
Okay, thank you, sir. Thank you. So welcome, Shomya madam, and good morning from India. I know you are now outside, but we are really thankful that you had joined. So my question to Dr. Warad about one issue you had addressed, the adherence. It is something which is always important for any long-term care. So what are the current challenges in ensuring patient adherence to long-term allergen immunotherapy, and how can this be addressed?
Yeah, it's a very important question actually, while treating these patients, because as already Dr. Saibal sir had shown the slides and all, how the coordination and the long-term benefits to form the IgG4 antibodies and not to have a relapse to the patients. At least 3 to 4 years immunotherapy has to be given. And that adherence is very important. It will happen only when the primary physicians, pediatricians, when they explain the patient about the importance of immunotherapy and the patients to keep over there. Because when there is no uniformity, and our colleagues, if they say, okay, we don't know about that, and that doctor is treating, he only knows. So then the patient does not have that confidence. So there has to be uniformity, how like a diabetes. Everybody has some or the other knowledge, and that is effective for the patients. So even in India, the pediatricians and the primary physicians are not still confident about that this works in these patients. But if you see internationally, last more than 100 years, the immunotherapy is there. And as in India, yes, as Dr. Saibal sir said, still we don't have that standardized, but does not matter that way. The same way, if the use increases in India, maximum people come into these therapies, then definitely that awareness and that confidence into the patient will improve that immunotherapy, because it has to be taken for at least 3 to 5 years. That's very important. So that adherence, why there is a dropping into that? Because people, once they feel they are symptomatically better, they leave, or within 6 months to 9 months, that patience is not there into the patients. So if they don't have that much response, they drop out. So, and they feel like immunotherapy, once it starts, there is no need to take any other medications. It's not that way. So at 3 levels, we have to work to form the IgG4 antibodies or long term against the IgE, specific IgE. Whatever the mast cell hyperactivation has happened or the inflammation is there, we have to control that also with the symptomatic medication, the safer ones. And whenever like people have a misconceptions that allopathy means side effects. So allergy vaccines or something, any vaccination, they feel like there will be a lot of side effects. So these are the misconceptions. So initial part, we have to counsel. So patient has to be counseled at a multiple levels, even to the staff level, to the reception level, even to the physician or the pediatricians also. They should also counsel that you are in the safe hands. If they don't have time. I can understand they don't have that much time, but at least they should give the confidence to the patient that you are in the safe hands. And that has been scientifically and research proven. Because in India, if you see a lot of alternative people, they give a misconception to the people like they are curing this disease. So it cannot be cured. So it can be a control, and the hypersensitivity to the normal sensitivity can be brought. And that will be achieved only with the education and counseling.
Absolutely agree with Vijay sir in that. Um, I apologies on joining late. I'm in Bangkok for the World Allergy Congress, and sorry about that. So, as rightly said, I was speaking to the people here. The representation from India is slow, and the data we have diversity about Asian conditions. We were talking here. We all do good work, but I think we don't publish it. I think going forward, that is my request. But and coming to the question, as Dr. Shambho was highlighting, how do we counsel the patients? And as Sir said, I think we have to just give them that confidence that this is so safe, and we can do it very well. Control the disease, that the quality of life cannot be affected. We can do it, but it's also important to get the patient on board. What do they want? I mean, if immunotherapy can be injectable or sublingual, though there is debate whether this skit is better over slit. But I think in pediatric population, sometimes skit adherence may be a little issue. The patient factor and the family factor has to be taken into consideration. Um, and if we are giving skit, that they have to dedicate time to come and complete the dosing. So I think it's important that we take the patient into account. What are the things to expect, and how long is the therapy, the safety profile, very nicely if we can explain it to them, and telling that the quality of life. Many a time immunotherapy helps arrest the progression of the disease, as we have discussed in the earlier sessions, that if we catch these patients in, especially in pediatrics, like if they have allergic rhinitis, and if we start immunotherapy, the progression to asthma would be less, and they would definitely benefit, especially children who are very physically active into sports, everything. So that would help them. And um, I think I usually stress a lot of time on the adherence and compliance. I think if we spend more time educating our peers and patients, I think the compliance and the adherence increases, and the success rate for the immunotherapy definitely becomes better. Having said that, cost also sometimes is an inhibiting factor for many of the patients, because it's not covered by the insurance in our country. But I think if it has a lot of good prognosis to increase the quality of life in our allergic patients with nasobronchial allergies.
Thank you, madam. Thank you,
I
sir.
would like to add, like,
Yeah, please,
actually
please.
now some of the insurance companies that they are covering the immunotherapy now, even the
So great.
biologics also. Yeah, it's a very good. It's very nice.
Okay,
Great.
sir. Thank you. Thank you for that information.
Thank you, sir. So actually, we got to know about few important C's in allergen immunotherapy practice. To ensure compliance, we need to give emphasis on those C's. Like as most important C is here the counseling. So counseling is very important. About another two C's, we are not going to cure you but control you. So this control, this concept is very important for all of us. I think when we are telling our patient about allergen immunotherapy from the very beginning, from the day one, we should be very clear cut. What we are having a plan, and this is a long-term procedure, 3 to 5 years. They need to wait. It is not just like a magic bullet. So these are few important issues we need to emphasize. And also another C, that is cost effectiveness. I am just want to ask Shoma madam about that cost effectiveness is also important. It is not just that cost is important, but as a whole, nowadays we talk about cost effectiveness about any therapy. So what is your comment on that, and what are the available evidences we have on cost effectiveness of allergen immunotherapy?
So in the beginning, as we counsel for asthma treatment, I think in the beginning we feel that this the cost may be humongous, but in the long run, the need for hospital visits, the episodes of acute exacerbations, the need for rescue medications go down with effective allergen immunotherapy. So it is one of the most cost effective treatment in the long term. And I think if we explain it in that way, definitely many patients will be willing to be on board for allergen immunotherapy. I think the emphasis when we are counseling should be on the good control of the disease, improving the quality of life, and the cost effectiveness in the long term. I think that is I feel that is a long way forward for the success of immunotherapy, because this is a therapy which goes on for 1 to 3 years. So I think each time and assess periodic follow up, I think will be the key for long term success of allergen immunotherapy.
Thank you, madam. Thank you. Just one question asked to Moitra sir by Dr. Abdus Salam from Guwahati. How do we calculate AIT allergen immunotherapy concentration from SPT reading? Example, if SPT antigen A having 7 millimeter, antigen B having 5 millimeter in duration, and we want to give both antigens in allergen immunotherapy. So I think.
Of course, yeah. How are you doing? Anyway, so see, the one thing is very important, that whether you want to give a monocomponent immunotherapy, bicomponent, tricomponent, is a mixture, or a monocomponent. Successful is best with the monocomponent immunotherapy. Now say, first you have to decide that which of the allergen is clinically significant for that particular individual. Now you have numerous cutoff values, clinically significant cutoff values, those in SPT and also the specific IgE. But these clinically significant cutoff values which we have, they're mostly for all the studies are on the Western population, not on the Indians. So say you have got 3 allergens and you have got a big skin pictus reactivity. Okay. As you are saying that some which is 7/7 or 10/10 or maybe a 12/12, whatever it is. But you have to, whatever you have got, again, it is a sensitization. So you have to again go back to the history and see that whether these highly positive allergens is causing the symptoms, some questions that you have to put into it and try to figure out as much as possible. I am not saying that you can just find it out or all the time, but as much as possible you need to find it out. But remember one thing. So it is, if you have found out 3 allergens which has high positive cutoff values and you want to include 3 of them in the allergen extract, and it is not that you will calculate the dose according to the size of the skin pictus reactivity. If the size is large and that is clinically relevant, you need to include all the 3 allergens. Then again, the therapeutic dose, you have to calculate it for each of them in the same way using that formula that I have shown before. Okay. You need to know that means for each this allergen, what is the optimal therapeutic dose, and for that dose, how much allergen extract you have to use from the stock solution, and you give the prescription accordingly. So that means if some individual is showing, say, the reactivity with the skin test, say DP, it's dermatophobia is coming to be yours 7/7, and someone is showing the 12/12, and in both these individuals, as it is clinically significant. Or maybe if you take in the same individual, you're giving this dermatophobia terronicinus 10/10, dermatophobia ferini 6/6, or whatever it is. And you find out that both of this is important for this individual, and you need to include both these allergen in the mixture of the concentrate that you have to prepare. So it's not that depending upon the reactivity, you decide the dose. Dose, you have to decide about what is the optimal therapeutic dose for the DP, optimal therapeutic dose for the DF, and that you have to calculate it. Because if it is a 1:100 weight by volume, it is 1:100 weight by volume, whatever the skin test reactivity. Then accordingly, you have to see what is the stock solution with the manufacturer have. It is 1:20. Then you have to calculate it by the same V1, C1, V2, C2. You find the V2 and you add it, and then you add the diluent and make the final solution. Okay.
So thank you, sir. Thank you very much for this explanation. So now may I ask Dr. Soumya, madam, because you were talking about when we are treating our pediatric patient, there is some hindrance on subcutaneous immunotherapy. So we know that we have some about of options like SLATE, sublingual immunotherapy, and in some cases of food allergy also we may plan on oral immunotherapy. So what is your thought on these two important modalities of allergen immunotherapy? One is sublingual immunotherapy and one is oral immunotherapy. Madam, you have to unmute.
Thank you for the question. So I think there are lacking data on sublingual immunotherapy in the pediatric population. The available data from the West is mainly on children above 4 to 5 years of age, not younger than that. It has shown promising results in the efficacy and the adherence, I think, and that is for the pollen and the dust mite. It has been approved by the FDA in the US and in the Europe. I think it is a regulatory issue in India what we have because of the lack of data about the sublingual immunotherapy. I'm sure with all the data which is coming up, the day is not far off when we may have sublingual immunotherapy approved by the Drug Control General of India. And we may have soon a standardized allergen extract for house dust mite in the form of tablet, which may be available in India probably next year or so. So that would be quite promising, which would be user-friendly for the pediatric population especially. So coming to the oral immunotherapy, I think oral immunotherapy in food allergies, we explore the option in patients who have had anaphylaxis to food and the accidental exposure causing life-threatening reactions again would be high. So we explore this area of oral immunotherapy in order to build up tolerance or sustained unresponsiveness in the children. So I think this is in a little infant stage in our country yet. We are doing in a small subset of patients with good results. But I feel this is an upcoming field in food allergy, and this can be a therapeutic option in patients who have had previous anaphylaxis.
Okay, madam. Thank you, madam. So, is there any already the studies ongoing in India also regarding the oral immunotherapy, or your any experience on this oral immunotherapy, madam?
Yeah, we have a small subset of patients, about 28 patients for oral immunotherapy we have done, and 22 of them have completed it. 4 of them had to drop out because of the gastrointestinal side effects they had during the course of the therapy. But overall, about 80% of them have completed, and they are taking it regularly in their diet. It is just like desensitization, what we do for drugs. But yes, this has been patients who had persisting allergies and very severe reactions. We have put up this for publication. I think sometime soon we may be seeing this.
Thank you, madam. I just want to share, though this is not that much scientific, but I want to share my own experience little bit with you. You know, madam, that I am an old patient of Professor Shoival Moitro, sir. When I was in my undergraduate days, I had this allergic cough, and there was a skin prick test done on me, and also the clinical history is suggestive of that I am allergic to coconut, and that coconut food allergy. So what I had, but I love coconut made food a lot. So I usually take after that a small dose of antihistamine and followed by one coconut based food in little quantities, and then gradually I increase the amount of coconut by myself. And what I feel that after maybe 3 years, 4 years, when they start to eat the coconut based food, I had not that much symptoms what I had previously having. So I think this is something, an area, just if we can follow the principles of desensitizations, what we do in allergen immunotherapy. Again, in oral immunotherapy, OIT, that can be a good options for those as you had mentioned about the food allergy. So thank you. Just one question raised by Dr. Pavitro Banerjee from Bakura, West Bengal, to Dr. Moitro sir regarding the compliance of subcutaneous immunotherapy in children, especially for when we are giving it 1 to 2 week interval during the build-up phase. So, sir, any particular comment on this question?
See, as you will understand, because as Dr. Soumya has said very nicely, that sublingual immunotherapy is still held up in India because of the regulatory issues. We know that it's effective, it's efficacious, and it has lots of advantages. So because of the regulatory issues, we are not able to freely practice sublingual immunotherapy, and we in our setup, we usually do not go for the sublingual immunotherapy. So the option is left is subcutaneous, and we have been giving this subcutaneous immunotherapy to our patients. But in the build-up phase, we give it once a week. We do not make it twice a week because twice a week is not practically feasible for any of the patients. But another point that we have seen that we usually train up the doctors from that nearby area. We have some regular sensitization programs where we train them up, they come us, and that has led to improved compliance for the patient's perspective because it's easier for them, for the patient to go and see the doctors nearby, we're staying nearby, rather than coming to our clinic. But those patients who come to our clinic from the nearby areas in the South Kolkata, so I have seen that even for the children I'm talking about, that the dropout rates are not very high. Okay, so there is dropout rates, but dropout rates are not very high. It's in the tune of, I may say, maybe around 20% is around is the dropout rates over after say 1 year or two years, which is quite acceptable in an Indian scenario. Because anyway, when the patients becomes fine, they stop taking everything. Okay, whether it's pharmacotherapy or immunotherapy or whatever it is. But otherwise they are pretty compliant, and majority of the patients they complete the treatment of three years. Because the later phase, maintenance phase, it's easier for the continue. There's a build-up phase, as you have rightly said. Main dropout issues are in the build-up phase, coming to the clinic every week. But this is how we just manage it in our setup, so that the patient is able to complete the treatment as much as possible.
Thank you, sir. Thank you very much. So, as also Dr. Yes, sir.
Shambhu,
Yes, you can leave. You can
thank
leave.
you so much.
Thank you again. Thank you for
Nice
yes, sir. Thank you, sir.
Okay, thank you. Yes.
So, namaskar, sir. So, may I ask Dr. Warad, a very important issue you had highlighted about that using video call while having the allergen immunotherapy, and I think this is something which is required, and the digital health is something in India is now growing up. Especially we learned a lot after this COVID-19 pandemic. So can you a little bit elaborate on the role of these digital health technologies in enhancing the overall effectiveness of allergen immunotherapy?
Yes, absolutely. It's necessary. Even 2011, with the Intel in Pune and Kolhapur, we had a program on the telemedicine. First time I learned on that. Even first time I learned about WhatsApp and Facebook that time only. And see, basically, after the COVID, even everyone, any patients know about the online things because their children were there. So it has become very easy post-COVID. And so primary physician also, if they have a consultation when the patient goes to them, and hardly half minute also they talk to the allergy specialist, the patient will have a confidence that, okay, we are having a, like, recently I will give an example. One patient was there from Mumbai, and I was already giving a omalizumab, and she went to there and she took it. So I had a coordination with the pediatrician over there, and so they had a confidence and they took it easily. The same way, that online consultation helps to have a good adherence and confidence into the patient that And because sometimes they have a local reaction or they get scared. Okay, so they will feel like the doctor has given a wrong injection or something that way. So rather than that, if we have a consultation and if we counsel to the patient, this is expected. And rather than that, I always say like how after the DPT, you have some reaction, that means the vaccine is working. The same way here also, suppose the patient has some reaction, that means the vaccine is working. So that way it helps to have. And even the questionnaire is, we can share on online and as clinically, because we can't do the IgG for antibodies and we can't do the mast cell activation test in India, the basophil activation test and all. So at least that questionnaire, how was the score of the patient, symptomatic score? Because we can't do the endoscopies everywhere, rhinoscopies to these patients, and we can't see how much is the improvement into the, because in Indian scenario, the people want immediate relief. So suppose there was a 100 score and now it is 80, 70. The people will say always when they come to me, कि doctor साहब कुछ फर्क तो पड़ा ही नहीं है. So why they feel that they want 100% relief within 1 or 2 months. So it can't happen. But if you have a questionnaire, then if you share online also to the patient, and okay, the sneezing now has reduced. Now the postnasal dribbling has reduced, the cough has reduced. If they say, okay, I can show them, okay, see, now previously you had all these blockers where there, sneezing was there, you had rhinorrhea, so now it has reduced. So that means you are having an improvement from 100 to 80, 70. So that also helps to the patients that way. Yes.
Great, sir. So thank you once again for this nice elaboration. I think this is very important, the practical tips. If we want to start our allergy in immunotherapy practice, this also we need to keep in our mind how to counsel. Each the thing is dependent on this counseling part, and there are lots of available validated symptom scores. I think that would be great use in our day-to-day practice. I think Madam is there, Shoma Madam, or we can ask later, Madam. So may I ask, sir, one another important aspect, as now the era is all about the precision medicine, the personalized medicine. And when we talk about precision medicine or personalized medicine in asthma or allergic disease, I think, yes, we talk about lots of about that biologics. And I think this is also now time to increase the awareness about allergen immunotherapy. So what is your comment on that? And if we just think one hypothetical situation when we can use both the allergen immunotherapy and the biologics. So how you approach that?
It's very good actually, because as I said, even the biologics are covered under insurance. So that is a very good benefit. Like that girl, only 17 years, with severe eczema, with rhinosinusitis, her quality of our life was very poor. So immunotherapy is going to take some time, and such a severe episode, we can't start the immunotherapy immediately, because if it gets triggered, they will have a problem. And that girl is having already a significant dust mite sensitivity. So once we started her on biologics, she has shown within 1 month only, she has shown a 30% improvement. After the second biologic, she has shown a 40 to 50% improvement. Even recently, I am doing a trial with itolizumab in COPD, dupilumab in asthma, omalizumab, 60 patients trial I have already completed in severe asthma. We have found a very good results. Those patients which required a oral or parenteral steroids, the side effects are so much. So these patients, immediately the biologics, monoclonal antibodies will block the IgA with the mast cells, so that the mast cell hyperactivation comes down. The patient have immediate confidence in our treatment. So the immunotherapy is going to take its own time, maybe 6 months, 9 months, 1 year. That is a long term. But if you use the biologics in these patients, the selective one, which require oral or parenteral steroids, they will act immediately. Even within 3 to 4 months, most of the patients have a good response. But practically, some of the patients we have seen, even next month also has shown a very results. Not only in asthma and all, specifically, we are doing a lot of studies on ocular allergy, because my spouse is working in ocular allergy. There was a 8 and 10 years old, both siblings had a significant VKC, and they used to rub and all. They were already started a Sils ulcer. We started a biologic omalizumab, and within 3 to 4 months, during Diwali also, they did not have any problem. The inflammation had come down. So biologics can be simultaneously used along with the immunotherapy also. Rather than that, it has a very good efficacy for the immunotherapy also. There are some trials which have shown that if the biologics are used, these patients, the immunotherapy also works faster and better.
Yeah. So you were mentioning about the synergistic role between these two, and I think that could be a future of our allergy practice. So may I ask Shoma Madam one important question that had been asked by Dr. Shuyok Phadke from Mumbai. Why does not sublingual immunotherapy work for food allergies? Any comment, Madam?
Sorry, I was disconnected in between. Sorry, Dr. Shankar, about that. So regarding this question about sublingual immunotherapy for oral immunotherapy for food allergies, I think it depends upon the protein content of the food. Uh, um, has not been that effective in raising the oral tolerance, even though it is absorbed by the immune cells in the submucosal area of the oral mucosa or from the Peyer's patches. The level of post dosage, the studies have shown that the IgG or the IgG4, which are the protective antibodies against the tolerance or the Th2 regulation, was suboptimal from the sublingual route. I think right now the more approved route is the oral immunotherapy. The upcoming routes may be epicutaneous, which may be far more easier and may reduce the adverse side effects of the oral immunotherapy.
Okay. Thank you, Madam. Thank you. So regarding the food allergies, Madam, if we again think about the concept of precision medicine, yes, one thing is the avoidance of the food. Yes, okay, it's okay, fine. But how you approach to the food allergies with the concept of precision medicine?
I think like any allergies, the diagnosis in food allergies has grown leaps and bounds in the last decade or so. Where we were thinking about allergen testing, it was mainly derived from a crude extract. Then we have gone into the specific components and then more specific components by the resolution or to guide tolerance. So like that, even in food allergies, when we are talking, before we used to do skin prick test or a quick on prick test where the standardized allergen extracts are not available. We have progressed on to do the specific IG or the components if required to know whether the patient will be having persistent food allergies or there is a possibility of that the patient could have outgrown that food allergies. So I think based on that, that will help us in deciding which patient may be a potential candidate who would benefit from desensitization or oral immunotherapy for that particular food allergy. I think we are also trying to incorporate that component testing, especially in the subset of population who have persistent food allergies. Would they be benefited from undergoing the oral immunotherapy in an effort to build tolerance to that particular food protein?
Dr. Shambhu, you are mute actually.
Yeah, I cannot.
You are mute.
Yes. So sorry. So actually, when we are talking about allergen immunotherapy now, there are many other indications also people are using it. If a patient is having some comorbidities like maybe atopic dermatitis or that sometimes allergic urticaria. Yes, urticaria has many other causes, and one of the major reason behind urticaria is autoimmune in nature. So what is your experience on that? If a patient is on allergen immunotherapy due to allergic rhinitis or maybe allergic asthma, and along with that patient is having atopic dermatitis or urticaria. So what is your comment? What is your observations in your patients that how the symptoms are reducing there? Dr. Warad, please.
Yeah, actually, as you rightly said, the urticaria has a different spectrum. It is allergic, but definitely the primary allergen and all. But if there is a strong history, family history, and if the patient is showing a hidden signs of allergic inflammation, and these patients, suppose they had a childhood allergies, and if there is a risk for further allergic march leading to the complications like rhinosinusitis, conjunctivitis, or asthma in these patients, and there is a significant correlation for the dust mites or some parthenium. It's a very common Congress grass, या गाजर गवत बोलते हैं इंडिया में. That there's a significant urticaria in these patients. These patients, we have seen a very good results after the desensitization also. But these are selective patients. And atopic dermatitis, definitely, if there is a significant dust mite sensitivity, we have seen a very good results. So even I had a patient 3.5 years old, which required, as I said, the other history was there. The mother had a rhinitis, the father had a sinusitis and asthma also. And this child required 3 admissions at the 3.5 years within 6 months for a bronchitis also. And significant atopic dermatitis was there. The dermatologist have already said up to 12 years you have to bear that. But once we started desensitization, like sublingual immunotherapy only I started. And within 9 months, even his dermatitis has significantly come down. So these are some patients, we have to select them with our experience and all, and we will have a very good results, like this girl also 17 years old. So that way, we have to be selective. In our population, I think we require more studies combining together. We'll have our own therapies. So, but definitely future is that we have to do more studies, basically.
Thank you, sir. Thank you. So may I ask Shoma Madam the last question, because you are also now in the Congress, that allergy Congress. So we have to excuse you also. But one question very important asked by Dr. Swatantra Burman from Kolkata. Has there been any large studies done in India regarding the compliance on allergen immunotherapy? And what is your observations on that?
I think as Vijay sir was pointing out, I think there is a paucity of the long-term data, birth cohorts in our country, even though we come from a huge population, populous country. But in our experience, I think with good counseling, with regular review, follow-up, and to cut down on the medication use as the patient becomes symptomatically better, I think the compliance to immunotherapy also is quite good, as they feel that the symptoms or the disease progression has been reduced or the control of symptoms are better. I think they are also very comfortable that with minimal side effects also, they will be very comfortable to continue the medications. So in my experience, and as well as I am sure that this is the experience from our colleagues across the country, that immunotherapy is quite safe, and the compliance has been good, and it helps us reduce the pharmacotherapy in the long run, and more cost effective for the patient, like where we think about the cost in our country, which is very humongous, and the healthcare system for the patient as well. It is more cost effective in the long run. So I think the compliance has been pretty good. In the last few years, we have been practicing immunotherapy.
Thank you, madam.
As Dr. Kumar said rightly, only thing is that somebody has to combine all of us, because problem is that still the immunotherapy is not practiced into the medical colleges. And in medical colleges, at least there are so many the lecturers and all, they can compile the data and all. Most of the time now in India, individual practices only that is practiced. So we have a data. Only thing is we don't have that much time to compile them, because I remember 2019 when I had been to the Munster University, Germany. Merck had already combined that data, but they withdrawn in India. But otherwise, that would have been a very good efficacious data for that. The mites in some of the indoor molds also, and some of the important pollens. They had combined that. I remember even the chart and all. So same way, some more players, if they come in India, it will be definitely helpful.
Thank you, sir. Thank you. And I think I can share my own data. That is during my thesis, actually, when I was doing my DM in clinical pharmacology, my thesis was on effectiveness and safety of allergen immunotherapy in real world setting. And my guide was Professor Shantanu Tripathi and Professor Shoibal Moitro. So we had a very good data of around 325 patients, which is the sample size is calculated and which is statistically significant data, and which had shown a symptom score reduction with medication score reduction without any much safety concerns. And in our setting, the compliance was 84%. So after one, obviously this was we know that for thesis we get only 1 year time. So 1 year is something which is very not very significant for allergen immunotherapy map, but we got this data. I think if we can continue that, and I think that almost after that 325 patients, still we have 300 patients data, maybe after 3 years, 4 years, like that. So if we can compile it, and we will get a very good data. And among that, one important issue is when and where we are doing the allergen immunotherapy. That is very important, because that depends on the allergen immunotherapy prescriber, the counseling level. So I think that is again a very important issue. It will vary from one prescriber to another prescriber depending on the counseling nature. And another important issue is the selection of the patient. If we are not selecting the proper patient, then the compliance will affect. And that is why we have a discussion today also, and last module also. So I think that is very important, and it is not like that. That's when we are talking about subcutaneous immunotherapy, the patient will be fear of needle. They will not take the injections later. But studies suggest that subcutaneous immunotherapy has better result, better adherence compared to the sublingual immunotherapy. There are certain studies which had shown that. But of course, we need a pan-India data, and for that, we need some more collaborations like people like you all, so that we can have some Indianized data. So once again, I am really thankful to all of our respected panelists. We had a long discussion about allergen immunotherapy. May I now request you, both of you, regarding a few take-home messages on these issues. May I ask with Dr. Soumya, madam, first?
Please, Dr. Soumya, you please have the, because actually I have to join another session. They are calling me. Yeah, please continue. Okay, thank you, Dr. Shambhu. And
Thank you, sir.
Thank you, sir. Thank you, sir. Any final comment from you, sir? Then.
Yeah, actually, as I said, the awareness is the most important among the patient and the physicians also, because the allergists, they are doing their best, but the primary physicians and pediatricians, they also should be educated more and among the community. That is the only thing. Yeah, and the more standardization will come when the maximum youngsters will come into this field and more players will be there, then the more standardization will happen. Thank you. Thanks again.
Thank you, sir. Thank you. So, Soumya, madam, your final comments?
Yeah, so I concur with my other speakers and yourself, Dr. Shambhu, that I think awareness among our peers, as you are rightly reaching out through your module, increasing awareness. Then regarding the counseling part, proper patient selection and standardization, this will all help us achieve the define the successful of the desensitization. So we all know that it will help, but with proper follow-up, counseling, proper patient selection, that plays the major key role in sustaining the allergen immunotherapy and the success of that program. So I think in the next few years, I think it is going to be very exciting for the field of allergy in India. I think with collaborations, I think we all can do much more for our patients across the different geographical regions of our country.
Thank you, madam. Thank you. So, thank you for being with us on this module, and we are again waiting for your lecture in the next module, and we'll start. The small announcement is like that. There, due to some inconvenience, we have to start next session, module 6, in 9 a.m. Indian Standard Time. I think madam will start the lecture from 9 a.m. Indian Standard Time, and I am requesting all of you to be present on that session from 9 a.m. IST. So once again, thank you, madam. Now, may I request our delegates who are participating, please complete your post-test questionnaire that had been submitted to you from our Imagika Health mail ID. And I think you have to complete it by today. And we will also submit the answers to all the modules in the WhatsApp group created by us for this particular course. Very soon, maybe by Tuesday, we will compile all the questions and we'll submit those answers. And one important announcement is like that after the next module, module 6, there will be 2 lectures by Dr. Soumya Nagarajan and Dr. Gayatri Pandit. But after that lecture, there will be an online examination, and for that online examination, you should have a proper internet connection, and you should use your laptop or computer, because otherwise you may face difficulty in submitting your answer, and that is very much time bound. For each question, MCQ based questions will be there, and each question there will be a certain time you will get to answer your question. So we are really hopeful to see you all in the next module, and where it will be first of all, there will be one class, and followed by there will be an examination, online examination. So again, on behalf of Indian College of Physicians, I want to thank you all for being with us in the 5th module. We are hopeful to get your attention in the module 6. Thank you. Thank you all. Thank you, madam.
Thank you.
Namaskar.
Thank you. Thank you.
So now with the permission